We get it. We know you don't want to talk about suicide, but you probably should be. We're a father-daughter team. Dr. Sam Buser is a psychologist and expert in the field of suicide. Kimmy Buser-Clancy is an actor, writer, and optimist who helps unpack this difficult subject. We're having a conversation about mental health and suicide prevention. We're hoping us talking about it makes it easier for you to do the same.
No matter how comprehensive this conversation is, it can't replace therapy. So if you're having dark thoughts, call 1-800-273-8255. That's the National Suicide Lifeline.
Let's begin. Welcome back to Leaving the Valley, the podcast where we discuss what you should know about suicide. I'm your host, Kimmy Buser-Clancy, and I have my dad, Dr. Sam Buser, with me as always, along with a special guest, Sherry Dusson. So Sherry is a Texas and an Arizona LPC and a LMFT in private practice, and the founder and director of the Center for Postpartum Family Health in Houston, Texas. Since 1999, she has focused her practice on new mothers, and in 2014, she opened the Center for Postpartum Family Health. Using therapists practicing under her supervision, they provide services on a sliding scale for the community. Sherry is a proud graduate of UH Clear Lake Family Therapy and a longtime clinical fellow at AAMFT. Thank you for being back with us, Sherry.
Thank you for having me.
And if you haven't listened, this is going to be the follow-up to a previous episode where we were discussing postpartum mental health. And the term people use is perinatal mood and anxiety disorders. The abbreviation that people use is PMADS. And that is what we're going to be focusing in on. This is the follow-up of that conversation. So if you haven't listened to our previous episode, I'd encourage you to go back and listen to that part and then join us for this follow-up conversation. So let's get started. When I was asking other women about this question about PMADS, about mood and anxiety postpartum, a lot of women told me that they knew that they didn't have postpartum depression because they weren't thinking about hurting the baby. And that was the only sort of popular understanding about what postpartum anxiety, postpartum depression might look like. And I thought that was so interesting because obviously there's way more nuance.
Yeah.
And then what it took was them feeling really lousy for a while to figure out there was more to the conversation than just because I don't want to hurt my baby doesn't mean I'm not personally struggling myself.
It's so strange, Kimmy, because I really know very few people with postpartum depression that would ever think about hurting their baby. I mean, that's just not part of what it looks like. The only folks that might be in danger of hurting their baby are the psychosis, people with the psychotic break. And that's so extremely rare. So why we've taken that one symptom of psychosis and glommed it on to postpartum depression, I'm not sure. I think some TV shows have kind of...
I was going to say, that's the headline grabber.
Yeah, but it's not even what postpartum depression is. Nobody wants to hurt their baby.
Yeah, and I think that's one of the sad misunderstandings about this. It's like women think because they're not at the absolute end of their rope, they don't need to do anything to take care of themselves. And it's like, well, that's not a great philosophy in life in general, but especially when someone else is so fully dependent on you. It's like, it doesn't need to be the worst possible case scenario for you to pursue getting some help.
Right, exactly.
I think this brings up the issue or question about severity of symptoms. So what's clear to me in listening to you is that PMADS is not an on-off switch. Like everybody has this severe disorder like psychosis and wants to hurt a baby or something. But there are lots of variation in the severity and the symptoms that people experience postpartum.
Absolutely, yeah. And there are a few conditions that need immediate attention, but a lot of this can be addressed in outpatient psychotherapy because it's about just helping the mom process what she's been through, come up with a treatment plan that usually includes some rest and self-care. I'm kind of jumping ahead here, but there is a way to help moms through this that don't involve hospitals.
Yeah. So I think one of the things that came up when I was speaking sort of with my my community of moms at large, was that there's this idea that PMADS is exclusively about the hormone shift. And as soon as my hormones level out, I'm done. I'm better. I'm back. So is it just about the hormonal shift, or could there be a little bit more to that? Can PMADS
Oh,
be
yeah.
about life experiences as well as this hormonal shift?
Absolutely. Yeah, it's not just about hormones. What I think when people are saying, why did I get this? And we never know exactly, right? But I say, look at the stressors. So that, if someone had a difficult pregnancy, if they had a difficult birth, if they're in a difficult relationship, if there are, stressful life circumstances, if they're having trouble breastfeeding, if they are extremely sleep deprived, there are things that trigger an illness that have to do with a stressor, but it's not one thing. For some people, it may be the extreme hormone drop, but that's not everybody. It could be uncovering trauma from the past. There's a lot of people that don't even know that they, maybe had some abuse in their history until they become a parent. And then all of a sudden, there are memories that come back. So there's a lot of things. But sometimes in a perfectly happy, stable life, just going without sleep is the trigger. And that's not really hormones, that's just sleep deprivation.
Right, right. And I think we had talked about, and I want to circle back, giving birth is a transformative experience. And so it might make you reflect on other things that happen in your life, like maybe becoming a parent makes you think about your own parents, and maybe it makes
Yeah,
you reflect or evaluate on your relationship with them, or possibly you've
yeah,
lost a parent,
yep,
which that would be really tricky to process, being a parent while grieving the loss of a parent. And I think all these things
absolutely.
come up, and I think it's interesting because we want to have like a simple bite-sized answer for most problems. So we want to say PMADS is just hormones and just give it 6 weeks. You'll be fine. Don't worry about it. You're going to love being a mom. I understand the comfort in having a soundbite like that, but I, I frankly think it's just a little unfair to assume that it could only be a hormonal shift and could not have anything to do with the past stressors of your life.
I totally agree. And I think it's a real disservice to just give that message to women that somehow you're going to love this and you're going to get through it and it's fine, because what happens is if you're not doing well, you think, well, then it must just be me. I must not be cut out to be a mother. I must not be good at this. And this kid is probably better off without me as their mother. And that is the bridge to the suicide conversation, because if somebody um, is is suffering in a way that it is not being normalized by their medical professional, then somehow they think it must just be a personal flaw. It's not actually an illness. And so that's where it gets very dangerous to not have our culture actually understanding these illnesses, because the mother will begin to think that it's some sort of defect in her and that her baby would be better off without her. And that's also the lie of depression, right, Sam? I mean, that's just what depression does. It kind of gets a negative story going in your head that somehow, you're defective and this is the only answer. And, unfortunately, some moms with depression and anxiety postpartum, you know, are at risk for suicide and complete suicide.
So this brings up for me the question about how long do symptoms of PMADS continue? And I guess that it would really be very different if you had, say, a more severe case or more severe symptoms and you sought treatment versus not seeking treatment. Could you talk a little bit about
Yeah.
the how long people's symptoms of postpartum mental health conditions last?
Yeah, I mean, we always say if they are having symptoms anytime in the first year after having a baby, we count that as a perinatal illness. But, like any depression, if it goes without treatment, statistically, some of it resolves. I think without treatment, depression resolves in a year or two, but some people it doesn't. So it just kind of depends on the person. But it's never. Sometimes early on, a lot of new moms would say, "I don't want to take medication or I don't want to do anything because I'm breastfeeding and I'm just going to ride this out. Well, we know that's not a good strategy because their depression has a direct impact on the baby's development. And so just kind of riding out a depression rather than getting help for it is not really what's best for your baby. And sometimes we have to have those conversations because there are times that medication is necessary as part of the treatment plan, and we need to make sure that the mother understands that her being well is the best thing for the baby.
I would add also, just because someone doesn't qualify as quote unquote technically clinically depressed or clinically
Yeah,
anxious doesn't mean that they
right.
wouldn't benefit from creating a plan for how they're going to take better care of themselves. I mean, gosh, I'm
Totally.
like, I want to sit down and figure that out right now. I mean,
Totally. And we call that just kind of an adjustment. A lot of our, the diagnosis is just around adjustment disorder, but having a postpartum wellness plan is something that we do at our center. We have a form, we have them fill out how they're going to get regular self-care, which is part of of really reducing symptoms. You don't have to be full blown, suicidal depression to get help. It may be I'm not feeling like myself, I don't feel great, I'm a little grumpy, and having a good self-care plan in place may be what they need to kind of get back to themselves. So we talk about exercise and a sleep plan and a support system and all of those things, because even people who've done a really good job of taking care of themselves will throw their self-care out the window when they have a baby. And that's usually the thing that is not helping them with their mood and anxiety. So we do a lot of talk around self-care, and it's not just pedicures. It's the stuff that really makes a difference for the symptoms and for their well-being.
I also want to add, because we're all about suicide prevention here, not getting to a crisis point is how you prevent suicide. So
Exactly.
saying, man, I have been working way too hard. I don't feel like I'm in balance with my baby, my life, my responsibilities. I'm going to do something now
Yeah,
is how we prevent suicide later. And,
totally.
as we talked about earlier, but especially on this subject, these symptoms are treatable. These symptoms will, for
Mhm,
most people, end. And
mhm,
these symptoms can be preventable too,
mhm, mhm.
especially if we take our self care seriously.
Yeah,
So going back to this question about seeking help or deciding to seek help, how does a person know that they should seek help? I've gotten to a point where I ought to seek help.
yeah. Well, there is a screening tool that is being used quite a bit right now. It's called the Edinburgh Postpartum Depression Scale, and or the EPDS, Postpartum Depression Scale. Yeah, and basically it's a 10-item questionnaire, and it basically is just assessing for mood, and it's assessing for depression. It's not really assessing for anxiety as much, but it's being standardized and kind of used as a standard of care in a lot of OB offices. Um, Other countries, like in Canada, you get an EPDS screen about 3 or 4 times during your pregnancy and postpartum time. There are some, offices in the United States now in hospitals. They'll give you an EPDS before you are discharged from the hospital. It's part of our standard intake process at our counseling center that you do an EPDS. And, it's not really the number assigned to it. I mean, there is a cutoff number. If they get a 10 or higher, you're symptomatic, you're positive for a positive screen for depression. But it's really about just talking through those questions with the client. And there is the number 10 on the EPDS is a question about thoughts of dying or suicide or going away. So we do screen for that quite a bit, but that's kind of a standard, simple, you know, practice that should probably just be a part of regular OB care.
The screener is offered at most doctor's offices. I know also at a pediatrician's office early on, when you take your baby in for their, I think,
Yeah.
3-day check, and often at their 1-month check, you might get those screeners again.
Yeah.
And then I think when I was speaking with a lot of women about this subject, they had a lot of thoughts about that screener, and it's not being as effective as maybe like it's great that it exists, but it's only as effective as the clinician who's interpreting it.
I know. I mean, it's usually a nurse or somebody on it's just a screen, it's on an iPad somewhere.
Yeah, and I think some people felt like mostly that just got filed away, and they really um wanted to have some kind of human follow-up even if they hadn't scored particularly high. A lot of women felt like, shouldn't someone be checking in on me?
Well,
And and of course that's not you're not on trial here or anything like that, Sherry, but I think that was something a chorus of women were bringing that up, that this screener felt like a joke at best. And a couple of women said that they scored significantly high and never had a follow-up conversation with their clinician, or at best were told to go talk to their general practitioner.
well, yes, there are huge gaps in care. I mean, this is honestly one of the reasons I started the Center for Postpartum Family Health is, we had been doing all this advocacy work around using the EPDS and telling all these doctors to do it. And they would say, well, yeah, we can screen, but where are we going to send these women? We just don't have any place to send them. And really, after having that conversation for 15 years, I was so tired of it. I just said, shoot, I'll just do it myself. I will start a center where we have clinicians who understand these illnesses, because, it was going to happen at this hospital and that hospital, and it just never happened. And I mean, this is not me, trying to say I've done something so great, but I really got tired of having that conversation about, if we screen women, where do we send them? And yeah, we're not seeing every single person in Houston, but we're doing what we can, because I do believe that birthing people have the right to good expert care. Like, it just, and the tragedies only happen when they're seeing people who don't know what they're looking at and how to treat it. It doesn't have to be a tragedy, but you got to have somebody who knows what they're doing. And that's really why our center exists.
So let me ask, if you are someone like, unfortunately, my friend who said, "Hey, doc, I'm feeling really anxious," and you sort of get
Yeah.
rebuffed. What are if you don't live in Houston, what are what's some best practices that someone who is aware that they're going through something, they've just had a baby, where might that person get help? Where might they seek support?
Well, there's lots of good online resources. There is an organization called Postpartum Support International that has lots of resources online. They have online support groups. They also have a network of providers throughout the world, but particularly in every state, there's a coordinator, and they kind of know who the practitioners are and who the doctors, who the psychiatrists are, because perinatal psychiatry is also a specialty now. And so there are some places like that. PSI has a conference. They have come up with a certification for perinatal mental health professionals. So that's kind of one of the main places. There are other groups as well, but there are online resources for people who don't live in Houston, and there are centers like this around the country.
I also think, while we're talking about the screener, that one of the things that comes up when you research this screening tool specifically is how it may fall short of the mark in terms of helping our minority mothers, our Black, Latina, Asian mothers connect with
Mm-hmm.
care and be properly
Mm-hmm.
assessed for their postpartum mental health.
I mean, this is another huge, huge topic, Kimmy, and one that is like very close to my heart. I'm super passionate about it. The disparities in health outcomes between Black mothers and white mothers is just astounding and frankly,
Shameful. Yeah.
disgusting.
Yeah.
Yeah. And so there's a whole lot of work being done. There's 44% of Black women will talk about having symptoms of PMADS. White women are twice as likely to receive treatment. So there's a whole lot of work being done. There's some Black maternal mental health coalitions that have formed that are really trying to address the disparity in birth outcomes and also postpartum mental health. But yeah, also if somebody doesn't feel like they're going to be understood or that it's safe to tell somebody that they're having symptoms, they're just not going to answer that screening honestly, because frankly they have a reason to not be honest. So yeah, it's about safety. It's about having those screening questions administered in a compassionate and supportive way, and having practitioners that feel like they're safe to open up to.
So I have a question from a guy's
Yeah.
perspective. So how do I know if my loved one, the woman in my life, let's say, uh, is struggling with PMADS? And if I recognized it, how should I go about talking with her about it?
Well, the first thing I would say is listen to her and believe what she says, because what we hear a lot is someone telling their partner they're not doing well and having that partner just kind of minimize it or saying, "Oh, you're great, you're doing great, you're fine," rather than what's going on, what do we need to do to get you help. I would say, checking in with her every day about how she's doing, not just about the baby, not just about who needs to feed and who needs to change the diaper, but really having time for that couple to check in with each other every day. And I would say each other, because actually men have a risk of postpartum depression as well, and it's being addressed and talked about a lot more than it used to. But if we talk about stressors, there are a lot of stressors for men as well. Sometimes it's around, just kind of traditionally the financial piece. If a woman stops working, she decides to stay home, all of a sudden the income's in half. He better keep that job. I better work more hours. There's a lot of stressors for the whole family, right? So I would say, that daily, well, the Gottman stress reducing conversation, the daily 20 minutes is a really good practice. But the other is that rather than minimize her symptoms, if she's telling you she feels horrible or she's scared or she doesn't feel like herself, you need to get her back to her OB. Really that's the practitioner to go to first. They may refer you to a psychiatrist or a psychologist, but the OB is usually the first place to go back to, because that person is already a patient of that provider. And it can take a while, as you well know, Sam, to get somebody into a psychiatrist. So we always refer back to the OBs. There's a lot of OBs that will prescribe medication, at least to start. They'll say, well, I'm not an expert at this, but I will start you on an antidepressant, and then I want you to follow up with this doctor down the road. Or the OB will refer to us or refer to another practitioner who might be a therapist who specializes in PMADS. So, it's really about believing your spouse and then, helping them find the resources. Sometimes, if somebody's really depressed, they don't even have the energy to call their OB or to figure out what to do next. As you know, Sam, confusion is a very prominent depression symptom. And so it makes it very hard to figure out, what am I supposed to do next, if I'm not feeling good. So a spouse can be really helpful in those cases. Well, let me call your doctor. Let me find out, what they suggest.
It's very hard for a mom to admit she's struggling, that either this bond isn't as strong as she wanted it to be, or that she's not feeling as joyful as she thought she might. Um, a friend of mine said, I kept expecting the music to play and the song to swell, and that just still has never happened. Um,
Right.
and I think a lot of women feel some sense of guilt or shame about the struggle to connect with their baby. How does that
Hmm.
relate to PMADS? How is guilt and shame a part of PMADS or just a part of the baby blues?
Yeah. Well, I mean, if someone is not feeling well, if they have an illness, it's going to be really hard to have that kind of normal connection and feelings of attachment. What we try to talk about when we talk about attachment is that it's on a continuum, it's not a one time thing, and that, you have time to build that attachment. And really, it doesn't, it's not immediate. For some people love to say, oh, the second I saw that baby or they put her on my chest, it was like love at first sight. Well, that is some people's experience, but that's not everybody. I had a baby, my second baby was a screamer, and she was so colicky and so difficult, and I was so stressed out. I don't think we attached till she was about 2 years old. I mean, I cared for her and I took care of her, but did I feel warm and fuzzy? And no, I was scared to death that there was something really wrong with her. She was a screamer all the time. And so, yeah, that disrupted our attachment. She was a high need, colicky baby, and I was worried and depressed and anxious, but I wasn't attached to her. I was just hoping she was okay. That baby just graduated from college, by the way, so she's doing all right.
Yeah.
But yeah, but
Way to go, baby.
That I think it's so interesting, that internal police that we all have that's judging
yeah,
ourselves and saying,
yeah,
"You aren't doing this good
right,
enough," or "You're somehow letting this little
yeah,
human down." And it's largely it's our own voice. I mean, it's influenced by the societal expectations. Do not get me wrong, but that voice inside that we could all benefit from saying, let's give ourselves a little bit of a break here. Let's take some grace, the
absolutely,
same grace we offer other people. Let's
yeah,
offer it to
yeah,
ourselves. Um, and I like
totally,
what you said. I don't think that it's talked about enough that the bonding journey is not a one and done deal.
yeah.
You're on that road with your kid for as long as you got. Yeah.
Exactly, and it changes all the time. I mean, then fathers don't put that pressure on themselves, and a lot of times, like they must immediately be bonded to their baby. It usually takes a while, you know, till that baby's talking to them or running around, doing, playing with their dad before they really feel that bond. Again, those are kind of traditional observations, but that's, I just don't think men put quite as much pressure on themselves to be the end all be all parent immediately as women do.
Tell that, Dad, think about that next time you're hanging out with my baby, your granddaughter.
I was thinking about that. I'm always looking for a chance to play with that
So,
one.
uh,
That baby's lucky.
yeah, yeah. Well,
Yeah,
the
uh,
yeah,
you're lucky to
the
have her.
bond
Hmm.
aspect. She's very bonded with my mom, who she spends a little more time with, and my dad's always jealous.
You're right. I am jealous.
That's a good problem.
So, are there any other kind of common feelings that come up when we talk about PMADs? We talked about guilt, we talked about shame. I know we've mentioned sadness.
Yeah. I mean, I think the other kind of unspoken common thing is the feelings of loss and grief, and just not a lot of space to talk about
Let's
that.
talk about. Tell me, what are we losing? What are we grieving here? The losing of our own personal identity, the grief of the life we've that chapter
Yeah.
we just
I
closed.
mean, right. It can be personal identity. It can be the loss of your body as you knew it. It can be the loss of your relationship with your primary partner. That changes. Statistically, that goes way down the first year postpartum. It comes back, but there's a lot of losses. It may be that a lot of your self-esteem came from really fulfilling work, and that it doesn't feel very fulfilling to be taking care of a helpless little baby all day long. And again, the message is often that you should be loving that, or somehow this is a vacation, that you're home from work, you get to take, and it's just so not that. And it's just such a terrible message to give a mother that she's going to get a 4-month vacation maternity leave as if, that's going to be restorative. It's going to be the hardest thing you've ever done. And we need to prepare people honestly, not tell them that it's going to be all hearts and flowers and that they're going to love it.
What about anger? Does anger ever come in here too?
Absolutely. I mean, anger is definitely a part of the grieving process, and it's a part of depression, and it's a part of anxiety. I mean, the Sam, anger is like the safe emotion on top. It's like what's underneath that anger that's a little bit more uh, vulnerable and a little bit harder to talk about. How scary this is, how sad you feel, how much loss you're feeling, all of that is much harder to talk about than I'm just pissed off that, you didn't do what I expected you to do, or this baby won't sleep, or whatever. It's really easy to be angry.
Well, that's especially true for us guys. I know that. We love our anger. Thank you very
Yeah.
much.
Very nice shield.
I think also a cousin of anger or a part of anger might be resentment.
Yeah. Well, for sure. Again, there's a lot of losses. There's not a lot of support. And there's a lot of lonely, tedious days. And yeah, I remember being resentful that my husband got to put on nice clothes and go to an office and go out to lunch. It's like, wow, must be nice. I'd love to put on some nice clothes and go out to lunch with my friends,
Yeah.
you know?
Or I would love to not have to get up for this feeding. I think there's like kind of that.
Yeah.
I think that's pretty.
Yeah.
I think that's pretty normal to be like, darn you, why do you get to sleep in?
I know, of course. You're only human. Of course you feel that.
You mentioned earlier, I really liked your comment, Sherry, about look at the stressors in one's life and how that will sort of feed into PMADs, if you will.
Yeah.
So I was thinking about some of the stressors that are particularly true or particularly consistent with childbirth. I mean, traumatic
Yeah.
birth experience,
Yes.
perhaps a miscarriage. So
Yes.
I wonder if you could talk a bit more about that, how that might relate to PMADs.
Yeah, well, I think anything unexpected and upsetting can be traumatic, right? No, there's so much talk about trauma now, but we could be talking about big T trauma, and in childbirth that might be in a hemorrhage or a stillbirth, or the loss of a twin is pretty common. And then just anything scary, emergency C-sections can be extremely scary. Um, things can go wrong. So there's a lot of opportunities for trauma in the birth experience. Also, what we're learning from all the research on Black maternal health is not believing somebody, not believing their pain, not believing their distress. You know, just a minimizing of people's pain. And so all of that, feeling unsupported and scared and unsure about what's going on, that is a recipe for trauma. There can also be trauma around disappointment, just kind of, this didn't go the way I wanted it to go. I had a vision that didn't happen. My family is not here for me like I thought they would. Everybody's disappeared, and I thought I was going to have all this support. There can be disappointment around gender, there can be, I don't know if that's trauma, but I suppose it could be in some cases. There's a lot of things that can be surprising and upsetting and unexpected that, can really contribute to those feelings of trauma. And, there's actual emergencies, and, a baby in the NICU, sometimes around, I'm thinking of a case of somebody where the baby was in the NICU, and the mother was very worried about the well-being of this baby, so she wouldn't leave and she wouldn't go home and rest. And she really was up for days worrying about this baby, and the mother had a psychotic break. I think we would probably consider that a brief psychotic episode that just came from the stress of this baby not being well and not sleeping and had just given birth, that was not a good situation. And she had to be hospitalized. But I don't think, she was schizophrenic. I don't think she's going to be, psychotic the rest of her life. But the combination of factors was really, stressors more than her human body could handle. And, no fault of her own.
Yeah, I really appreciated your comments about the different kinds of experiences, unexpected experiences, traumatic experiences. Made me think also of people who, their child has some sort of birth defect, some kind of
Yeah.
medical problem themselves, and
Yep.
boy, it seems like to me that could really contribute to all these feelings we're discussing.
Absolutely.
Yeah.
Absolutely. Disappointment. Yeah. Illnesses with the baby. We have we have clients show up that just need a place to talk about, my baby was born with this particular issue, and I don't feel free to talk about how sad that makes me or how worried that makes me anywhere. I need a place to just process that. Yeah.
Can PMADs be different birth to birth or pregnancy to pregnancy?
Yeah, they can. If somebody has had postpartum depression, they have a much higher chance of a reoccurrence. It's, at least 50% chance or higher that they're going to, that biochemically they could have a reoccurrence, but it doesn't mean that they're just set up to have another miserable experience. What that means is that they need a plan for starting treatment, maybe right at birth. There's a lot of doctors that will start prescription medication in the third trimester or right at birth, or they'll have a follow up with a psychiatrist like right after birth and just see how they're doing. If somebody has had postpartum depression, sometimes they're afraid to have a second baby, but we will often help them kind of tailor a wellness plan so they've got something in place before, so they're ready. And that usually does the trick. The worst cases of postpartum depression are the ones that go undetected, that go on and on and on. And by the time they reach out for help, they've been depressed, for weeks and weeks and weeks. And it's harder to get somebody stabilized and well. They can still get well on medication and with therapy, but that takes a little bit longer if they've been depressed for a long time. If they're coming in right at 2 weeks postpartum and they're making sure that everything is in place, they probably can prevent another reoccurrence. Sometimes that means hiring a baby nurse or having a family member stay so that person gets adequate rest after they've given birth, rather than just like, I'm going to be up all night breastfeeding. And it's like, well, maybe that's not the best thing. Maybe we'll bring the baby to you to feed, but you stay in bed and you twilight sleep, feed, and then we'll take care of the baby so you can rest. That kind of thing can really make a huge difference in keeping a second postpartum depression from flaring up.
A little earlier, Sherry, you talked about the bonding experience and how, for example, depression, a mother's depression could affect that bonding. And it
Mm-hmm.
made me think about, does PMADS, is it affected by the bonding, or does the PMADS affect the bonding, or is it both ways? Does that make sense?
Yeah, yeah. I mean, I really think the PMADs affect how the mother feels about the bonding. Like, I'm not feeling connected. If the baby's being held, cared for, fed, the baby's probably feeling connected. I mean, mothers love to put a huge guilt trip on themselves. Like, my baby's picking up on the fact that I'm not happy. Well, I mean, we have to be super careful with stuff like that, because if your baby is being cared for, nurtured, held, changed, fed, chances are your baby's fine. They're not picking up supernaturally on the fact that you're unhappy. And many, many mothers with postpartum depression are doing a beautiful job of taking care of their babies. It doesn't always affect their caretaking. It's just kind of how the mom feels. And so, we really just try to assure them, rather than worrying about whether your baby is bonded, let's just get you well. And I think you will see that the bond is fine.
I'm going to go ahead and stop the episode here for today. We spoke with Sherry for quite some time, and there's a lot more information that we're going to cover. So please join us for our next episode as we continue to talk about PMADs. Thank you so much for joining us, Sherry. It's been a true pleasure talking to you today. Please join us next episode as we finish up this conversation. If you like what you heard, please like, subscribe, rate, and share. We're always trying to grow our audience. Mental health needs champions, and we invite you to be one of them.
And please check out our website, leavingthevalley.com. There's a whole lot more information for you there.
And you can follow us on social media. We're at Leaving Valley on Twitter. We're at Leaving the Valley on Facebook. And we're at Leaving the Valley Show on Instagram. Thanks for being with us again today, Sherry.